Well, thank you for the invitation to speak today. Also, I want to thank everyone who serves on this commission. The efforts in HIV/AIDS are really highly dependent upon community participation. In fact, I come from an agency whose research is based in the community. And having come from, if you will, the ivory tower of Columbia University and now working in the community, it's quite a change, but in the final analysis, it's all about really good science. And as I say to many of my colleagues, it's all about the numbers, stupid. I'm going to go very quickly over some concepts. I've been working on this issue of HIV and aging since 2002. And clearly it has now emerged as a major issue within the epidemic, not only here in the US, but also globally. Let me see how I do it. This is data from the LA County. And the reason I'm showing this slide, which is from 2010, is to give you a sense about where you're going. And if you look at this data, you can see that between the ages of 40 and 49, this is back in 2010, all those people are going to age 10 years, right? By the time we get to the end of this decade. So they're going to move forward. And what's happening is that if you add together those numbers, 38, 25, 10, you're going to come up with 72%. In fact, this is the number that when we calculate an estimation of how many people over the age of 50 will be living in any given community, that number, 70, 72, comes up consistently. So whether it's 70 or 72 or 75, not important. The reality is it just keeps increasing. This is, again, data from your county. And what's interesting about this data is you don't need it to be a statistician to see that in the middle range of 40 to 49, there's a decreasing number. Why? Because they're moving into the 50 to 59 category, and then more into the 60-plus category. And that you have still a fairly high infection rate in the younger populations, and there's one HIV infection is one too many. But this is a static model, and basically, this model is not going to change. There's nothing you can do to it that changes the actual outcome of this fact that the population is aging, and it's dominating the epidemic. You know, we live in an aging society. In fact, the USA and other European countries are the first societies we ever know about that are aging, where the aging population will dominate over the younger population. And it's exactly what we see in the HIV population. This is an estimate of the national data, and there too you can see by the end of this decade we'll be at 70%. What happens is when you cross around 2015-16, the curve begins to accelerate. So, how do we begin to notice that there was something different about this population? And the first indication to many researchers was that physicians were looking at more and more non-HIV related cases. In fact, the management of HIV, which is never all that easy, but nonetheless is a clinical condition that is relatively easily managed. So their attentions have been drawn away from CD4 viral load to other illnesses. And when you have two or more other illnesses, many of them associated with aging, it's called multimorbidity. And these are typically two or more chronic conditions that are not curable. I have many data like this. This data just shows you that for all these conditions, when you look at the blue bar, then the orange, and then the purple one, that over time, over aging, the number of people who have these conditions increases. But one thing I want to make sure you notice, everyone doesn't have heart disease. Everyone doesn't have diabetes. Everyone doesn't have Hep C. Only certain percentages do. So as is the case in our lives, we tend to look at the plane that falls out of the sky, but we don't look at all the planes that are flying normally. We tend to emphasize the negative. There's good reason for that, but the reality is that by and large, the larger HIV populations in the US and across the world are really rather stable. But there are people who exhibit multimorbidity, and these are the medical challenges of an aging population. I want to bring your attention to the fact that depression doesn't change very much at all. It remains 3 to 5 times higher in this population. It was in 1980s, it is today. There's something askew there. So this is often called the complication of success, and these are the common comorbidities that we see in this population with high frequency. And this list can change a little bit at the end. Recently we had hearing loss and macular degeneration. Depending on what pathology you want to look at, they're going to find an increase in that particular issue. So why? Why are we here today? Where did all this come from? Well, first of all, people are aging. It's a good thing. You know, without art, no one would be aging into their 50s, 60s, 70s, 80s, 9th decade of life. And where does it come from, these occurrences of non-AIDS-related illnesses? They likely come from the inflammatory response, which HIV contributes to. From the moment of infection, there is an inflammatory cascade that occurs. And if I started now, I might finish next week describing these cascades, and you'd be bored to tears. But nonetheless, it's a very complex series of mechanisms that involve everything from skin to the gut. So the cascade is complex and it's omnipresent. But this article in Time magazine shows you that for all these conditions, regardless of HIV, the inflammatory response is the etiology, is the mechanism by which these diseases occur, or these pathologies likely occur. Once again, everybody doesn't get cardiovascular disease. Everyone doesn't get cognitive dysfunction. Everyone doesn't exhibit frailty. But those that do are those that are most concerned for medical and social care. This is from our ROA study, research on older adults with HIV, just got into press. And you can see here the number of people with multiple morbidity. The ROA is red, and the green is the national sample from N. Haynes. So again, compared to that population where we can control for a lot of variables, there is an increased incidence of comorbidity. This is another study. You look at the red bars, you can see that over time, age, this population is exhibiting more and more comorbidities. The reason I'm talking about multimorbidity is that in general, management of multimorbidity is the domain of geriatricians. They know how to deal with this. It's not the domain of HIV treating physicians, maybe of family physicians. So this has been our concern, is that the kind of care that this population needs has changed. So one of the paramount questions that people have, are they aging differently? And we heard many times in the past that they were experiencing, older adults, accelerated aging if they were infected with HIV. Well, that's a hypothesis. No one's proven it yet, and the data is very elusive. And I'm going to kind of show you why. First of all, I want to show you what we're talking about. If we talk about accelerated aging, it means that you have a certain number of diseases that occur before the general population gets them, earlier. On the other hand, there is accentuated aging, meaning you have more of it. Not earlier, but more of them. So the data to date, well-controlled data, supports accentuated aging. There is no accelerated aging. You know, in fact, if you go into the literature and look for diseases that are accelerated aging, they're very few and very far between. This is a phenomenon that what people talk about, but you know, the data is just not there. So, and part of the reason I want to debunk that for you, and I have an article I think it's going to be distributed, a chapter I just wrote with a physician from NIH, is that you know, there's self-fulfilling prophecies. You know, you're going to be hit by a car tomorrow, or you're going to win the lotto. I don't know about that one. But, you know, if you believe something, it can happen. So it doesn't change anything, whether it's accelerated or accentuated. It doesn't really change anything. But I don't want to create fears where there need not be any. We shouldn't do that. So what's interesting about multimorbidity and inflammatory response is that many things cause an inflammatory response. We put HIV aside for a moment over here, which is hard to do, I know, in this context. There are many things that contribute to multimorbidity, many things that increase inflammation. Smoking, number one. In New York City, 13% of the population smoke on average. When we look at older adults, no matter what we do, what kind of study we do, 50 to 60% are smoking. This is an extraordinarily high number. And smoking is in and of itself an inflammatory behavior. I won't go through all of these. The history of substance use, poor diet, no exercise. When I say no, I mean no. Hep C co-infection is an inflammatory response inducer. Minimal, even that 1 drink a day or 2 drinks a day we all hear about, that's been just disproven that for people with HIV, it should even go near that. Alcohol is an inflammatory inducer. Let's see, stress of any kind, like depression. Right? Or I remember when I first started my community work in Arizona, and a person would come to me, and this is in '94, and they would say, well, we just got diagnosed, and I look at them and say, you know what, whoever causes you stress in your life, I don't care who they are, your mother, your boyfriend, girlfriend, get rid of them. Stress is takes an incredible toll on the body. Social and economic isolation, which we all hear about constantly, and this is usually induced by stigma. And one of the big factors we see emerging in our large data sets is not working. People who don't have a purpose in life, right? It doesn't mean work for money, but even volunteering, whatever. If you don't have a purpose in life, your outcomes as you age are really very negative. Does it contribute to the inflammatory response? Yes. And lastly, long-term opioid use, which is common in this population as well, as you know. So these are all contributing factors to inflammation. HIV, actually, in a way, is the smaller one of any of these. So these are things you can change. We can't change your age, sex, or genes. This is set in stone. But other things like weight, smoking, illicit drugs, etc., these are all things that can be changed. And there's no pill out there that's going to change these. I think we saw the extraordinary event of art in the middle 90s. I mean, without art, we wouldn't be here today. And yet, we are looking for a pill to resolve these things, these very complex issues on the right side. Don't bet on it. Many people are looking for other ways to reduce inflammation. They have not been successful today. If they were, everyone else would be equally happy, because most people suffer from these comorbidities who don't have HIV. And there are psychosocial pieces. This is really interesting of Korea. You know, all diseases, all challenges in health are not resolved by a pill. Many of them are a function of social circumstances, and many are amenable, some are not, especially those that are kind of drilled into our system. But this is a good way of looking at it. When I ask people if you're in recovery or not, recovery is a lifelong, very, very highly impactful behavior. Look at the percentages. They're very high, very high. And we see this constantly over the last 10 years. Here's substance use in our 1,000-person sample in New York. And what I want to draw your attention is to the last one, alcohol. Alcohol becomes, as you age, anyone, the drug of choice. This is depression. Depression, having been a professor in psychiatry and neurology at Columbia, depression is eminently treatable. Why is it not being treated in the HIV-positive population? Here are people who are positive on the right side. Here is the normal data on the left side. And here are people who are blind, visually impaired. If anyone should be depressed, they should be. But look at the HIV population. High, high, high rates of depression, which are constant, not only here in the USA, but globally. It is not being treated. It's given too much short shrift. And then finally, people live alone. You know? A lot of people want to live alone when you're younger, but as you get older, if you live alone, you don't have someone to bug you, to take your pills, pick up your slippers, don't fall down on the rug, et cetera, et cetera. Living alone is social isolation, and yes, that's where we find ourselves in this epidemic today. So multimorbidity management. Without going into a lot of detail, I work with the American Academy of HIV Medicine and American Geriatric Society for now the last 10 years. And geriatricians kind of got it. They know how to deal with this. The end goal of a geriatrician is to keep someone functional. It's not to give them many pills. Yes, they give them medication, but not a ton of them. It's to keep functionality going. And this is the primary, tenets, if you will, of geriatric care. And the first one is patient-centered. As long as the patient is sentient and understands what's going on, they should be part of the decision process. Too often, the physician, by default, is the decider, right? Or the nurse practitioner, whoever. They shouldn't be. It needs the input of the patient. Maybe the patient doesn't want to take all those pills. Maybe the patient doesn't want to be dizzy every day because they're taking medication. The patient needs to know and make a decision. And then social supports. As you age, social supports. They could be your own, informal caregivers, but also out in society, like the AAAs that come down from the Department of Health. They have provided enormous support that the HIV community must be aware of, because we can't create them ourselves. It's too costly. There are people out there who know more about aging than anyone in this room, and we should be aware of that and begin to engage them. Polypharmacy, we mentioned. Here's one very good study, shows the number of people who have drug interactions, that's the red, that might be injurious. These kind of go by the wayside. No one pays attention to you, because if you go to the doctor and he or she doesn't give you a pill, they didn't do the right thing. Quite the opposite, especially as you age. I talked about work with the American Academy. This has been really a great exercise for Korea and myself, to work with people who are working in the world of geriatrics. They have a very, very different view about how care should be delivered. This booklet, which I think we're going to be sending more, was written by Korea, but with three geriatricians and our local ACT-UP editor, who is an amazing guy. And it tells clients what they should do, what they should know, and what they should ask their physician. We've already gone through almost 40,000 of this, and it just came out, I think, in last March or something like that, last year. So use that. This was the ROA, the original research that I mentioned. The book was in 2009, I think. And now we have done multiple focus groups in New York City, San Francisco, Oakland, and those feed into the survey of ROA. We have a research advisory council, and now ROA is being done in New York, New York City with Cornell Medical. In New York State, we're looking at rural and urban areas. We're now actively collecting data in our Tale of Two Cities, Oakland and San Francisco. We hope Los Angeles will come on board soon, as well as Palm Springs, where we just got a PCORI grant. And I got a call from Minnesota and one other state, I think it was Oregon, who want to do the same thing because they have unique populations there, which is kind of amazing to us. And we're going to be adding Baltimore and Atlanta soon because in active negotiations. The point of ROA 2 is to get a large database that people can use for years. It will be accessible to everyone so that they can look at the relationship between social norms and medical issues and see how best to design programs which everyone needs, and they need to change across every agency we have in the USA. These are our funders, which have been very generous and very fortunate. You know, research is always hard to find. I call it the bastard child of society. But we've had many entities come to the table and help us, including the state of California. So without going into the weeds here, I think the need is to change care, to educate both the provider and the client, reverse that order, as they engage something that's not necessarily HIV related, but is occurring within this population. Thank you.
Do you want to take questions now, or do you want to wait until everyone's done? Okay.
Good morning. My name is Jeff Bailey. I'm the Director of HIV Access at APLA Health. And this morning, I would like to provide some information about a study that we've been engaged in since July 1st of last year, examining the social service needs of persons living with HIV older than 50 years of age in LA County. I'm going to be doing a bit of a tag team approach, and I will provide the introduction and the conclusion and recommendations, and my colleagues here from APLA will discuss the findings as well as some preliminary findings as we continue to engage the target population in a series of focus groups. In fact, we have one today at 11 o'clock. So I will go ahead and move on here. And given that I'm one of these older adults, I don't know if I can use this. I'm just to move this through. So Matt, Keshav, and myself will be presenting the data today. So what I would like to go over just some preliminary statistics specific to Los Angeles County that LA County EPI provided for us in the fall as a backdrop to the work that we're doing. And then to go over the components of the Healthy Living Project, we want to talk about some of our both completed and preliminary results, challenges and rewards, and recommendations to the Commission. Just right up front, just understand that this was a pretty aggressive and ambitious study on a limited amount of money. We proposed to do about 30 focus groups over about a 9-month period. And this will end on June the 30th. So once again, we're still in the process, but we hope that you find that the information we provide will be really helpful. We did this not only obviously for selfish reasons because APLA has a very sizable population of older adults living with HIV, but also to inform policy as well as this planning body and what we could do in order to promote the stability, the independence, and the health of this particular population. So back in the fall, this may look a little bit different from some of the data you've seen before because, as you know, it constantly changes. But in the fall, we did request HIV EPI to run some data for us. And of the 58,000 people living with HIV that they projected in the fall, 45% are age 50 and above, and they also anticipate that this number will increase by another 30% by the year 2025. So this certainly, as Stephen said, is a population that we will continue to contend with as treatment continues to advance and people continue to live well into their older age. Just an example, we have a female client who accesses our food pantry regularly, and she's 94 years of age. So what our response was, we responded to a call from Gilead Sciences regarding HIV and aging. They were generous in providing support to us. Ricky and his office of the City AIDS Coordinator has also been generously supportive of this project as well. and well as Cal State University Dominguez Hills, who has been our IRB. So the aims of the project that we instituted way back in July is to learn about where and what type of services older adults living with HIV in LA County receive, also to provide information to them, which also was kind of an anecdotal component, because as we started looking at doing the focus groups, we found that there was a significant gap in knowledge on what services are available, and particularly for women. The women's groups in particularly, there was a sizable gap in what they knew was available for them in LA County. To understand barriers and challenges that people living with HIV and AIDS face, as you'll probably would concur and understand, and for Rebecca, housing is probably the biggest challenge that these individuals indicated that they're facing. Understand experience with HIV care and support services and identifying those service gaps, and explore possible program activities and strategies that older adults living with HIV perceive will assist them with managing the psychosocial and physical complexities of living with HIV. So as opposed to, we knew that ACREA has been doing this work for a while, really looking at a lot of the medical outcomes and particularly gaps in the medical field. We really wanted to look at the social support systems. What are the systems that help this particular population remain engaged in care, retained in care, also to help them live independently. So I'm going to now just turn it over to Matt to talk about what the structure of the study is.
All right, thank you, and thank you all for having us here today to present some of our findings. I've got my water here, which is the #1 anti-inflammatory, right? So hopefully we can all resist some of these aging issues. So I want to talk a little bit about this study. We did conduct focus groups, and our goal was to do 3 groups with 5 different priority populations: MSM, transgender, cisgender women, heterosexual men, and also a series of groups in Spanish. In order to be eligible, the participants needed to be 50 years or older and living with HIV, residing in LA County, and a member of one of those groups. And they did receive some remuneration for their time. Now, we've done a number of these groups already, but the project is still being implemented as we speak. And so we're still analyzing data. This says MSM groups are complete and the analysis is complete, but from a researcher perspective, our analyses are never really complete. We're always thinking about the data. But we have looked at the transcripts and the data from the MSM and the women's groups, and we are starting to look at the results from the heterosexual men's groups and the transgender group as well. Just beginning recruitment for the Spanish-speaking focus groups. And so I want to say a few things about the findings from the MSM group. Unfortunately, we have very little time to present a lot of data on a topic that is very large and expansive. And so we're only just starting to see the tip of the iceberg here, and I don't have time to go into all the details of the study's methodology because we're trying to get to some of the key findings real quickly. But I am happy to answer questions. We did recruit individuals through convenient sampling for the most part, and this population with MSM was about 50% African American or Black, and about a quarter Caucasian, and about a quarter Latino or Hispanic in racial ethnic composition. So looking at the MSM group briefly, we did see some particular themes, and we're trying to emphasize themes that we kind of saw in each group. With this group, we saw them talking about just being grateful that they were still here, and at the same time acknowledging the challenges of aging with HIV, but many felt that earlier in their lives they would never be at this point. So there was a sense of gratefulness, but also a sense of having quite a few needs, since they experienced what we call the Lazarus effect and hadn't necessarily planned to be aging with HIV or retiring. And so what we saw was really concerns with housing and finances, and also with being alone as they get older. As this participant said, if I accept that I'm getting older, then it's the older gay dilemma, which is you don't have a house or kids who will march to your rescue. So I'm comfortable being like a kid rather than acting like an adult, because I don't want to think about the larger gay aging issue, because it's kind of a dead end. And what I think this person is referring to here is a number of challenges around the gay dilemma, which sort of crystallizes their experiences, in my opinion. But the experience of being gay and aging is hard all by itself. Not only because many gay men don't have kids, some do have kids and family, but also because the community doesn't really value older gay men, and particularly in the venues like clubs, where many of the guys, and we couldn't have all the quotes, but there were some really moving quotes about feeling invisible when they go out to the clubs. And so this issue of social isolation, I think, is really key, in addition to some of the more practical things about finances and housing. Another slide here, asking for advocacy in housing and finances. One quote says, I think part of the issue here is that we lost a generation. So we don't have anybody to model from as to what it's like to be older and gay. And we're now sort of the generation that has to create our own lives at this point and decide what we want to do in our formative years. There's no manual and no book. We haven't gone down this road before, and we don't have anybody really to talk to about it. So emphasizing another aspect, I think, of isolation, in which they didn't have the benefit of the older generation to really pave the way as to what it's like to be aging and gay, or living with HIV as you're aging and gay. And I think this applies to a lot of the populations. Another quote, I think housing is a huge issue if you want it affordable. It's not available on the income that we're on. Anything that is realistic has a 3 to 10 year wait. How many places have services for seniors, let alone seniors with HIV and AIDS? It doesn't exist as far as I know. So there's a lot of issues packed in here very tightly. I wish I could unpack all of them. But I think clearly this speaks to the Lazarus effect, the fact that many folks didn't plan on owning homes and retirement and working, and now face a number of really quite important and serious issues around retirement and planning, in addition to social isolation. I'm going to stop there, although I could talk more, and introduce our next speaker, who's going to share some of the results, preliminary as they may be, from some of the other groups. I learned in Toastmasters never to leave the podium alone, so that's why I'm waiting for you to come up. Keshav. All right, thank you.
No worries. Just a mic. Thank you all for having me here. While we get into these other groups, particularly with the cisgender women, transgender women, and heterosexual men, we felt it was really important to have group moderators who reflected the populations. So for the women's groups, for example, we had actual cisgender women come in and lead the discussions and navigate what the clients were saying. For the trans group that we had, and I'll go into a little more detail about that later, we had an older transgender woman come in, so that way the clients could feel a lot more comfortable and more apt to sharing with someone that they felt a similarity with. And same with our heterosexual men's group. So specifically for the cisgender women's group, often this population has spent their lives being caregivers, and that doesn't change if they get HIV. They're still taking care of their families, their children, potentially their partners, even their parents. And this role very much manifested in a lot of their discussions, but it also came at the price of them often forsaking their own care in order to take care of their family needs. Regardless of that, the participants expressed similar gratitude to what the MSM participants expressed in terms of having survived so long with HIV and being privileged enough to make it to old age with HIV. So from this quote that we have here, "But my independence, I'm just getting into what it is that I'm going to do with myself, because I'm like this lady here. I have been a caregiver for over 30 years, taking care of hospice patients and seniors, and all this kind of stuff, you know. And I don't want it to be that. Oh, now it's my turn. Somebody come take care of me." And this quote, again, there's a lot of loaded information in these quotes that we picked. In this particular one, this participant is explaining that her whole life, she's been a caretaker, and she's worried that as she's getting older, there's not going to be someone that's going to be available to take care of her. But now she wants her health to be a priority as well, because she's getting older. She spent all this time investing in her family or other people, and now she's worried about her own health as she's getting older. Specifically in terms of services, the cisgender women that we talked to specifically talked about support groups that target older women who are living with HIV. And this specifically was important to them because this focused on their needs as women with HIV, and they wanted to simultaneously expand their social networks to find other women who would understand their situations, as well as enhance their degrees of tangible aid in terms of potentially finding people to take care of their children or their families, or to provide them with physical assistance for other options that they would want in the future. In addition to that, they also talked heavily about transportation assistance. In these two quotes that we have here, and transportation, ever since I've been around and living with this, transportation has always been an issue. That's why a lot of females don't go to doctors. Transportation is not provided. So I took the bus here today, and I was about 15 minutes late, so I apologize for that. But the bus and even the trains here are really unpredictable. And for a lot of our participants, this actually is a physical barrier to them to getting their medical care. If the transportation isn't really easily laid out for them, then they're more likely to not get their medical care because they have other things that they have to take care of at the same time. And unless it's really simply mapped out, unfortunately, it's more than likely they won't be able to make it. And then I hope we have more groups so we can get it out to the community and older women, especially older women. We need more groups like this to let women know they are not alone. And that was the biggest takeaway from that quote, just because for the women that we gathered for these discussions, this was the first time they'd really been in a room with so many people who were over the age of 50 and living with HIV and who were women. So this was not only an opportunity for them to provide their insight on a particular health issue, but also a cathartic experience to get a lot of anxieties and worries and their own personal fears off their chest. So we just wrapped up the heterosexual men's groups last week, and we're in the middle of analysis right now, but I can share a little bit of some of the findings that we have. So the heterosexual men participants reported a sense of pride in maintaining their health, and this manifested in their ability to make their doctor's appointments, for example, to stay medically adherent, and to stay away from risky behaviors that might impede their ability to take care of their own health and to enhance their holistic health management. The knowledge that they had, they explained, often gave them purpose in terms of their ability to move forward and to live productive lives. They were also very candid about their struggles with past substance abuse, and often that combination of HIV infection and past substance use prompted as a dual cue to action in order to promote their self-enhancement of their own health and management. And so we have this quote right here. "That's why I like to come to places like this, because first thing I do, I go to see what the reading material is they got. Like here, they talk about all the latest medications. What it does gives you the breakdown on all of it, and it gives you helpful information that you normally wouldn't get nowhere else. Seeing what they talk about or what the subject, I didn't know that before. Let me check to see my case manager about providing it if they do this here." So this quote really explores how curious this population is about protecting their own health and about what new information around them might actually translate to their abilities to take care of their own health. They reported being very interested in HIV research in terms of new medications and in terms of new therapies, and often this resulted in very proactive discussions with not only myself as the group organizer, but also with their HIV service providers and case managers, whom they would ask a lot of these questions to and ask for their opinions on to see if it would be a good thing for them to pursue. Specifically for this population, some of the service programs and desires that they expressed were care specifically on chronic diseases. And as we saw from Dr. Karpiak's presentation, multimorbidity is a very big issue for people who are aging with HIV and with each of our populations, so discussions came up. For this population, this was probably their chiefest concern, just in terms of they felt the efficacy of taking care of their HIV. That for our participants, they knew how to take their medications. They knew if they had issues with their medications to speak to their provider, and if they had issues that were related to HIV, they knew who to reach out to. But in terms of managing things like diabetes at the same time, or symptoms with chronic pain or fatigue, that's not something that they had their knowledge about readily. And that's something that they felt they wanted to capitalize on, but they didn't necessarily know where to start. In addition to to chronic disease-related knowledge, they were also interested in other support groups, specifically for straight men living with HIV, so they could have a safe space to talk about issues with mental health and chronic diseases and depression and just their struggles as straight men living with HIV. So we have 2 quotes here. Maybe too, a lot of people with HIV have depression problems, and I think like you, have a group that maybe has that problem with depression, and you hear something from him, it might click, you know? Maybe one might be feeling like this, you know? So this participant was explaining to us how having these sort of support groups to talk about mental health and depression would be helpful, because they might feel alone in feeling some of these thoughts, and then having that environment where someone might share a similar feeling, they won't feel like they're struggling or they're having this unique personal issue that no one else is having. They would see that others have this issue too, and they're not struggling with it by themselves. If you don't tell the doctor that you are having this problem, he will never know. They should be helping you with this instead of sending you all over. They didn't tell me that with this disease, I would have all these problems growing older. So yeah, screening would be helpful. So I think historically, when talking about HIV, the talk has often been concentrated on things like managing viral load or keeping up your white blood cell count. And now that they're getting older, they're used to having these conversations, and they know if there's an issue going on with any of these health metrics to talk to their doctor and find ways to improve these specific health metrics. But now they're working with other health metrics aside from just HIV. They're working with blood glucose levels, for example. They're working with hormone levels. They're working with chronic pain and with tiredness and with neuropathy potentially. And these are things that they want to potentially be focusing on in terms of their clinical care. So we also did groups with transgender women. Right now, we've only done 1 group, and we're actively recruiting for a 2nd group, which will hopefully be happening in the next few weeks. So these results that we have here only reflect the group that we have done so far. Overall, the transgender female participants that we had reported high levels of past trauma, which meant that their transgender identities and their safety as trans women often superseded their concerns of HIV and aging. Their primary concern was being safe, just being okay. Participants reported that they didn't feel represented or respected or accepted within LGBT circles or even HIV service organizations. And so for them, again, aging didn't appear to be much of their concern, as did their service needs as transgender women. So in the downtown area or slummish areas of Hollywood or something like that, it's very much there's not unity with the gay society, transgender society, HIV society, stuff like that. There's no unity. I think that's very ugly, because I feel like everybody, this and that, under that rainbow should be able to unite, because society is against us. So why are you, you know? And from this quote, they were just explaining that it seems confusing that even though society seems to be marginalizing them already, communities that they felt should be in their favor and supporting them don't readily support them, and they don't feel that they're readily supported. And unfortunately, this comes as a really big stress, because it contributes to feelings of feeling like maybe they're alone, maybe they don't have that robust support that they might want. specifically in terms of what they would want, specifically they advocated for educational programs within communities as well as for service providers about transgender health and transgender issues, just so everybody can get to a certain level of competency in terms of being able to provide care for this population. Job opportunities and workshops for transgender women. So specifically job training skills as well as more employment opportunities in various fields for this population so they can get out into the communities. Housing in areas where they don't feel they're unsafe. So a lot of housing, for example, is concentrated for trans women in the Skid Row SROs, and they advocated for places maybe in South LA or in Hollywood. And then also transgender employees in service organizations. And this was a really big comment that came up very much in that first focus group that we did, just because the reason why we had a trans moderator was because we wanted the trans participants that we had to feel comfortable sharing with someone that they felt a kinship with. And ultimately, this sort of kinship is something that they also want to see in an HIV service organization or in any service organization, someone that they can identify with and also someone that they feel they would be able to trust based on the fact that they are both transgender and there's an understanding of similar issues and similar experiences. So this one particular quote, "I want a job, I want to be around, I want to help other transgenders, I want to do things. I'm just tired of being in my car, I'm tired of not being able to work with transgenders. I'm tired of places like this not having job openings for us out here. It just irks the hell out of me." So there's an opportunity so there's definitely a need within this population for the chance to be advocates in places, for example, maybe like APLA or any other organization in order to provide direct service to this population as a community advocate. And having that person in these positions at these particular organizations would be very paramount in terms of making them feel comfortable and feeling respected. Did you want me to? Following the Toastmasters rule.
So I'm just going to go ahead and wrap up some of the challenges, limitations, and recommendations from the data that we've thus far collected. Obviously, this is simply a snapshot and only representative of those people who attended a focus group. They were screened prior to attending to determine eligibility and also to assess to ensure that we had a right mix within those particular groups. So recruiting transgender women and heterosexual men over the age of 50 has particularly been a challenge. We have filled the next transgender group, but we're hoping to do 3. So that is something that is ongoing. We actually added the heterosexual male group because early on, when we started recruiting MSM, we had a number of men calling us wanting to participate, but they didn't qualify for the criteria. And so we discarded some of the other elements of the study and decided it was really important to add this particular group to the mix. But it has been a bit challenging as well to recruit that particular population. Ensuring, obviously, geographical representative sample. We all know living in LA and the geography of Los Angeles in general is always a challenge, but we did make a significant effort to have these focus groups in different areas of the county. And lost to follow-up, people who would report coming to the focus group and then just would not show up despite numerous calls. So the rewards, obviously gratitude for providing a safe space for the community to come together, supporting one another, appreciation for having such a project that emphasizes their needs as persons living with HIV and getting older, and gaining an understanding of the diversity of aging and among persons living with HIV. I sat in a few of the focus groups, of the male focus groups, and one thing I think that we were a bit surprised about is that these men were extremely resilient and they were very happy in the place that they are right now in their lives. For those particularly that had previous histories of substance use, they felt that that was, as one guy said, that was the kick in the ass to get his life going again. And so while there was some of the doom and gloom and depression that we noticed, there was also, I would say, far more people that are very content with where they are right now in their lives. So recommendations that we would come out of this, things to consider, is medical and social service providers should be trained to understand HIV and aging simultaneously and how they interact with one another. There is a disparity in kind of our HIV care delivery system in that we have HIV specialists, but they may not be a geriatric specialist. And so that knowledge, particularly amongst not only within the medical community, but within our social service providers, particularly in MCC teams, to understand the combination of getting older and some of those needs, as well as an understanding of what the senior services are in Los Angeles and how can we work and partner with them in collaboration, because as we know, we can't and don't always need to do it all. Future programs might include persons living with HIV and actually the planning of programs, that they're geographically accessible, inclusive programs. And what we mean by that is most of the groups did not want to be how we separated the focus groups. They don't live their lives like that. They don't live just among women or just among MSM. They would like programs that are inclusive of all persons getting older living with HIV. Specific services targeted for their age group, that should just be 50 and older. Economically considerate. What that means is we often say affordable. Well, affordable may be very differently, mean different things to people along that socioeconomic scale. And finally, a collaborative between organizations and clients. They felt that there still continues a bit of a turf war amongst agencies, and that they would like to see agencies collaborate and partner with one another a bit more. So before we go into questions, I just really want to thank Gwen for inviting us to do this, because we came to the commission, I think, in the fall and talked about what we were planning to do, and now is coming to fruition. And once again, this is only a snapshot, but hopefully it will provide some further guidance to this body, as well as policymakers, about what we can do to a population that's going to continue to grow. So thank you all very much.
Thank you. Let's give everybody a hand.